Good morning, or rather good afternoon. Thanks, Professor Kate, Professor Dong, ASNS, Vietnam Neurosurgical Society. Greetings to Professor Yagal, Professor K, Professor Grossman. Really wish they were here with us today. So I'll follow Award's cue and stick to time. And Tanya, please feel free to crack the whip if I exceed. So we had a discussion about gliomas, and I would be discussing about this particular entity, histologically benign, but a killer. Killer in terms of quality of life, killer in terms of the patient psyche, the family psyche. This is not discussed quite often in meetings for two reasons. One, it is rare. And second, we do not know much about it. And let me tell you why. So no disclosures. So this is how I break my talk. What is known about this particular entity? I'll rush through that. And what is not known, or what is controversial. And unfortunately, the management part, which is the most crucial part, is controversial. So rare, just 1% of CNS neoplasms, a little more in children. Primarily seen in the first decade, or maybe up to may extend up to the second decade. No gender predisposition, but if it happens in females, it takes a little virulent form. You have two entities. It can just happen sporadically, or it can run in patients with neurofibromatosis. And when it happens in these two categories, there are some distinctions. In sporadic entity, it is usually unilateral, whereas it is bilateral in neurofibromatosis. But those with neurofibromatosis generally tend to have a slightly better prognosis. And they are less often symptomatic than the sporadic entity, more likely to progress in the sporadic entity. Presentation, we all know, it's usually revolving around vision, or may cause proptosis if it involves the optic nerve. But you can have this kind of presentation, especially with the type 2 or the chiasmal variants, where they can grow large, they can cause obstructive hydrocephalus, diencephalic syndrome, macrocephaly. Imaging also, I wouldn't go into much because it's quite straightforward. But this is something that is important with all these neuroimaging modalities. This helps because quite often with the supracellular tumors, we are in a doubt regarding craniopharyngiomas and other supracellular varieties. And this tractography helps because you can find the fiber, especially in optic nerve gliomas, you can find the tract ending in these gliomas. And fractional anisotropy, as you do with DTI, it not only helps in surgery, it also helps to prognosticate, because a dip in FA usually implies a bad prognosis. And this volumetric assessment, which is being propagated by this group in Israel, again, which seems to be the mecca of research on neurofibromatosis, again, helps in surgical management. These are all known facts. Something which interesting in imaging is quite often in patients with neurofibromatosis, you might find these kind of hyperintensities along the optic tract. These need not necessarily mean tumor always. Nobody yet knows the significance of this. I have a couple of patients because these kind of lesions, hyperintensities on MRI persist throughout, even in sometimes after surgery, may not imply tumors, do not know the role of this. They may or may not keep progressing. Of course, evaluation is not complete without a detailed ophthalmological evaluation and endocrine evaluation, because they are close to the hypothalamus, and you can have hypothalamic disturbance as well as along with growth hormone deficiency, which again is a poor prognosticator, as well as precocious puberty. Now, most of them are low-grade pilocytic astrocytomas, but unfortunately, as we had the discussion in the morning, nowadays, low-grade gliomas or grade 1 gliomas are seldom diagnosed. Majority of the gliomas not tend towards grade 3 and 4, especially with the CDK2NA and so forth. If there is a pilomyxoid variant, it generally implies bad prognosis. So if you have an optic pathway glioma of the pilomyxoid variant, it generally indicates a bad prognosis. Fortunately, most of them are pilocytic variants. Now, how do these tumors progress? Some progress, some remain the same, and some, if you're lucky, regress also. Regression, unfortunately, we don't see much, but anecdotal case reports are available. But one thing of caution is optopathic gliomas are one of the low-grade gliomas which are known to metastasize. So Putting a shunt for these patients, we need to be careful because there are case reports of them metastasizing to the peritoneum as well. So what are the predictors of deterioration? Most important predictor is initial presentation. If the child or the patient is symptomatic at the time of diagnosis, he is likely to progress. Compared to the other ones like in neurofibromatosis where you might find them incidentally. This is a summary of the prognostic factors: age less than young, visual impairment at presentation, the chiasmatic and the posterior tumors, pylomyxoid, and the female variant, which I already described. Now, management outcome in detail, but just before we go into the controversial or what is less known, I would just summarize this management algorithm which has been proposed by the Israel group. So the primary modality of treatment right now, if it is not causing raised ICP, is chemotherapy. So if you see this flow chart, one on the left, so primarily it is chemotherapy, and if chemotherapy fails, that is when you think of doing biopsy and even surgery. I would come to that in detail because I mean, what is more interesting or what causes more dilemma to us in management is what is not little known about this entity. So the first is the classification between neurofibromatosis and the ones with neurofibromatosis and the sporadic variants, and these entities I will just discuss in detail. Having said that, the gliomas with NF1 associated with NF1 have poor prognosis, have better prognosis compared to the sporadic. It's not the rule. I just show you some cases with this patient of mine, a 17-year-old with an optic nerve glioma. He's been on follow-up for 6 years without any progression. Now, what do we do with this lesions? He has an intact vision, lesion remaining same. On the contrary, there is this patient with a neurofibromatosis 1. He had an optic nerve glioma, excised once. The optic nerve was also cut, but he presents later, few years later, with this kind of tumor, extension beyond into the chiasm. This is another child. This is the one I was telling. Neurofibromatosis 1, poor vision. If you look at it, there isn't any lesion along the optic nerve or the chiasm. It is more in the optic tract and the latter part of the optic pathway. And this patient has hyperintensities all along, bilateral. Compared to this patient, a large chiasmal glioma with an intact vision. So these are management dilemmas. You have patients with small lesions who are symptomatic. You have patients with large lesions which are not symptomatic. Again, seldom described, but they can bleed as well. This is a young patient who bled and presented to us. Again, a young research scholar, we had to do multiple surgeries, including a shunt. So the first dilemma is optic pathway gliomas can be associated with neurofibromatosis, and the contrary. Neurofibromatosis, 1/3 of them can have optic pathway gliomas. So do we screen all patients with NF1 for optic pathway gliomas? So that is the first question, because even if they're asymptomatic, they might be having optic pathway gliomas. Second is the nomenclature. This is the old one. Type 1, type 2, type 3, the Dodge classification, but we have different variations and modifications which have come, including this one from the Tel Aviv group as late as 2021. The classification has been modified to include not only the location, MRI location, but include neurofibromatosis, age, and molecular markers. And so molecular markers is being integrated more and more into, and the chiasmatic variant has, so the anatomy you see is just one part of the classification. So, but how do we classify these kind of tumors, multi-compartmental large tumors? So what I want to clarify, I want to highlight here is classification into either of time does not help us in deciding the management. And one particular interesting observation which I want to highlight here is this. I personally feel that this optic nerve gliomas, the chiasmatic hypothalamic gliomas, the thalamic gliomas, brainstem gliomas, tectal gliomas, basal ganglia gliomas, these are all invariably low-grade gliomas, pilocytic variants, but by virtue of their location, they turn to be fatal, or not fatal, but morbid for the patient. So I personally feel they all belong to one particular entity of gliomas, and we need to discuss about them together. Now, to decision to intervene, that's the most crucial part of it. Decision for surgery. Of course, if it's an optic nerve, isolated optic nerve glioma, the decision is simple. If there is progressive proptosis, but in a blind eye, an intact vision. The policy, the principle is wait till the patient becomes symptomatic, especially in terms of an optic nerve glioma. If there is preserved vision, wait. The problem comes in small children because majority of these are young, small children. How do we assess vision? Sometimes it becomes very difficult to assess vision in these patients. And small children doing a repeated MRI also becomes difficult because each time you do an MRI, you have to subject them to general anesthesia. Now, there are some of these tumors are large, multi-compartmental. So in these, again, there's a role of surgery. So what the role of surgery is limited in optic nerve, isolated optic nerve gliomas, in view of progressive proptosis or when there is visual loss. Large tumors, there are two indications primarily, basically for CSF diversion, or if there is intratumoral hemorrhage, or there is a large exophytic component. Whenever we do surgery, the aim is maximal safe resection because being too aggressive with these tumors can result in significant morbidity. Having said about the role of surgery, this is what the consensus statement about optic pathway gliomas recommends. There's limiting the role of surgery to tissue biopsy, to sporadic optic pathway gliomas, and that too in the terms in a background of clinical trials, or those with atypical. So when the diagnosis is doubt, you might do surgery, or when you want to, in a case of to confirm the tissue biopsy. So what is the policy which we follow in our institute? Anterior, what I mean is intraocular optic nerve gliomas. If the patient is blind with proptosis, I go for surgery. Not blind, wait for the patient to become symptomatic. If the lesion is posterior, by posterior I mean hypothalamic variants, the ones which mimic a craniopharyngioma. If there is raised intracranial tension, do a debulking plus or minus a shunt. If there is vision or endocrine or hypothalamic involvement, again debulking only for the exophytic component. Don't try to go in for a radical resection because it's almost always causes a lot of morbidity. Chemotherapy, if you're sure of the diagnosis, is the first line of treatment as per current guidelines, unless in scenarios which I mentioned earlier. It's a gentle chemotherapy with vincristine and carboplastin. Radiotherapy, especially in neurofibromatosis, patients with neurofibromatosis, we need to be very careful because there is a neurofibromatosis patients are highly sensitive and it is for malignant transformation, and radiotherapy, especially in neurofibromatosis patient, needs to be avoided. So assessing outcome in these patients is again difficult because of the reasons which I mentioned earlier. There's always will be residual tumor. And sometimes, as I said, the MRI features, you can have hyperintensitivities which may not necessarily be tumor and it becomes difficult to follow up. Visual assessment is a problem in these children. And social functioning again becomes a difficult assessment parameter in these children. These are some of the meta-analyses which have been published in the last 5 years and a few surprising results. All of them, usually the progression-free survival is good, overall survival is good. And chemotherapy and radiotherapy in this study and the subsequent study, you would find that surgery, there was not much difference between surgery, radiation, and chemotherapy. And most of the patients, despite with or without treatment, had an overall survival. So this is what I wanted to highlight. These are low-grade tumors. The patients generally survive with deficits. So what is the future for this kind of tumors? A lot of work going on. And most of it, as I said, what was discussed based on molecular markers and targeted therapies. So that is going to be the end thing. So targeted therapy might soon replace chemotherapy, surgery, and radiotherapy in this. And there are a lot of focus or sites which have been identified for low-grade gliomas. So to summarize, I can see Tanya already giving me the indication. So optic pathway gliomas continue to remain a riddle wrapped in a mystery inside an enigma. And I prefer to call this the children of a lesser god, because these lesions do not kill in that real term of mortality, but the quality of life is affected for them as well as the family. They are low-grade tumors, quite often resistant to radiotherapy, chemotherapy, and biological markers and targeted therapy at specific sites where this biological markers act would be the future. Thank you.